We definitely know that. But they're getting sicker and it's happening faster. Some of it is hype, some of this is real. And this is where we have to try to balance what we really do know. So next slide. So this I got this morning. This is the number of COVID cases in the past week. And the light blue are adults and the dark blue are kids. So actually you can see that the number of pediatric cases are not bigger than what they were in the big surge in the, in the middle of this graph, which was in the winter, in the big surge. But the thing is that they are climbing. Next slide. Here's another way to look at it. COVID cases in children in the past week. And again, they're on the uptick. Next slide. And then this is by state. And these are not all, they're not all states, but the line, the dotted line in the middle, I think it's dotted, that's is the population. And then do you have excess number of cases based on what the population of children are? So 10 states report that 18% or more of the cumulative cases are in children. So if children make up 14.4% of the US population, then there's more cases. And if you look down the list, West Virginia is over the line. Where that says overall percent of children, it's about 5 or 6 lines up. We're in the medium shade of green there. So we are over the line of the percentage. More children in West Virginia by percentage have COVID than make up the whole population of our state a little bit. Next slide. I think we've got to think about this. So are we fixating on these endless loops of the what ifs? Oh my gosh, younger, sicker, quicker, all these things. Well, we hear about the case of a child who was brought in and then was pronounced dead in the ER. I read this on one of the news reports. Those are tragic, but are those really what is really happening with children? And are we missing or maybe not recognizing our broader needs, especially if you have children in your household and if the parent is just obsessing with, oh, what about wearing masks and are they going to get sick and are they going to be too close to their classmates and what if they get admitted and what if our hospitals get full and the breathless, endless what ifs. And I will tell you, I think we all know people like this, either people at work or someone in our family or a good friend who is constantly on the, oh my gosh, what if? So I like the word mental gymnastics. Are we victims of our own worry? And do we need to take a little more rational thought even amid this uncertainty? So I will tell you, I work with a wonderful group of colleagues in Peds ID. There's 3 of us. And I will say the rational one is Dr. Weiss and Dr. Gupta is the scientific one. And maybe she and I do a little more mental gymnastics and Marty is the one who helps us be more rational. But I think all 3 of us at times are able to be rational and say, we need to slow it down. We need to not be on the bandwagon of, oh my gosh, what ifs. Next slide. So this has been shown that we are seeing more severe COVID infections in children. We are. Now, what is the evidence? Well, I found one study and it's from Brazil. It's in the Yale Press that more of the children who were hospitalized with COVID-19 infection, 44% needed ICU care, 17% ventilated, and 3% died. And this was not data that really included a lot of the Delta variant. But otherwise, do we really know that is it more severe COVID infections because the Delta variant is causing more severe, or is it that because we just have more kids being sick, we are going to have more kids hospitalized? Or is it really, on top of that, the more than what proportionally we would expect to see from SARS-CoV-2? And I think that is really still not completely answered, because the kids who are being admitted are, for the most part, the teenagers who have a comorbid underlying condition, and the number one for us is obesity. So next slide. Now, I will tell you, this is not helpful to hear from our non-pediatric colleagues and say, oh, well, now you're seeing, welcome to COVID. Oh, you haven't had really COVID in pediatrics, and now you're dealing with it. I think that's really not helpful. And we all have dealt with COVID in our own ways. And we are dealing with COVID in pediatrics in a setting of the context of school and parents and unknown and the anxiety with masks, as opposed to in the adult world. Now you have vaccines, you've been wearing masks at work, you've been able to do work from home, and it hasn't been disrupting your developmental, emotional, behavioral maturity that we expect for children. So I would like to really say to people, don't make comments like this, because it's really not helpful. Next slide. Well, there is data emerging that there may be a greater risk of, it's now called long COVID. I was calling it long haulers, but I think the official term right now anyway is long-term COVID or long COVID. It really isn't known. So there is one study that was in Acta Pediatrica that looked at 5 months after acute infection in kids with proven COVID, and a third had 1 or 2 problems, and a fifth of them had 3 or more problems. Now, these may be self-selected out because there probably is a whole lot more COVID that kids have had that maybe didn't come to being queried or be included in the denominator. So are we really have the right, we know what the numerator is for having problems, but do we know what the denominator is? And then the other thing that we know is that, do you have a control group who maybe has other illness, and how many have problems 5 months down the road with, say, cough or asthma or something, say after influenza or RSV. So I think we have to look at this, and I think that we'll maybe get answers to these down the road. Next slide. So we do know that more children are being hospitalized. We've seen, at least I've seen on social media, Texas, Alabama, Arkansas, Florida, pediatricians, physicians have voiced concerns that PICUs are full with limited beds. Now, our PICU is full right now. We have limited beds. We have RSV, we have trauma, we have congenital disease, we have all kinds of things in the hospital. So I think if you look at any given time, PICUs across the United States are full most of the time. And there are times of the year, probably winter, most normal winters, this year maybe hasn't been so normal, when PICUs and pediatric hospitals, children's hospitals, have been at 110% capacity. So I think that we have to also look at that and say, are we going to be overrun? I think wait and see. So next slide, I'm sorry. So here are two slides that I found online, again, looking at hospitalizations, not just COVID infection, but hospitalizations. And I think the one on the right, it actually came from the Washington Post, but it was an article about COVID in Arkansas. And then the blue are the hospitalization rates in Arkansas compared to even just US pediatric hospitalizations. And yes, there are more hospitalizations in Arkansas for kids than in other parts of the US. Next slide. So these are all headlines that we've seen, and I put the references from where these came from. And they're pretty reputable news sources. NBC News, actually I can't read my own slide now, The Atlantic magazine, NPR, and these, I've read all these articles and they're very, I think they're very well done news articles, but they are not peer reviewed articles to say, you know, are children really sicker with the Delta variant? I think the time will answer that question. Next slide. Well, we definitely know that children are at risk for MIS-C, the multi-inflammatory system in children, inflammatory syndrome in children. And these mimic Kawasaki, and they usually occur 2 to 6 weeks after COVID, usually a relatively benign or asymptomatic COVID infection. And these are children who are usually older than what we think of with Kawasaki. We've had, in the winter, we had quite a few, and what we found was that the admissions for MIS-C were always a week or two lagging behind the peak admissions in, admissions in adults. So I will tell you, I've been on 2 out of the last 4 weeks on consult service. We haven't had a case of MIS-C. We've had COVID. I wonder if we're going to see MIS-C maybe the end of August, September. So next slide. One thing we do know, we are in RSV season in August. So there is an alert out now about increasing infections with RSV. And we're actually in an area now that are susceptible, premature, and cardiac kids are being treated now with prophylaxis, Synagis, when normally we would be starting that in November or December, anticipating the RSV season for the winter. We really had no RSV, none this past winter, because we were social distancing, we were masking, and now because people have been out, kids have been out, babies have been out, toddlers have been out, big people have been out. And I'm also aware of several adults who have tested positive for RSV, who have been hospitalized with viral bronchitis, pneumonitis, bronchiolitis. We don't really call it bronchiolitis in big people, pneumonia. So, and that's in our ICU. So what we have not seen is co-infection with COVID and RSV. But I'm sure there are places who are seeing that. And I think that has me worried, because we definitely know that one of these infections can make a child sick, especially if it's the first time they've ever had RSV, but co-infection. So we will have kids during a typical winter season who get RSV and flu, or RSV and adeno, or adeno and flu, or, you know, the combo, and that's very worrisome. So we definitely have other viral illnesses that are circulating. Next slide. What about transmission of COVID by children? Well, we know that children under 12 are known to transmit, but far less than adults. Although the viral load may be higher in the airway, for whatever reason, this is a mystery. This has been a mystery. We know that the over 12 crowd, the teenagers, their COVID acts like adult COVID, and they're more likely, they transmit just like adults transmit. There was the study last year that was published that looked at 90,000 children and didn't find, this was in schools, in their school system, and didn't find a proven transmitted case. Now, what about the Delta variant, and is it different? And I'll tell you, we really don't have any data about children in transmission with the Delta variant. Next slide. What we do know about the Delta variant is it's, so if you look at it in the log sense, if it's it's 1,000 times more contagious than the regular SARS-CoV-2 and most of the other variants. So it's a 2 log difference, right? And that's 1,000 times, 10, 100,000. If I did that math right, maybe it's 3 times. Anyway, it's 1,000 times more transmissible. So we could infer that children are more likely to transmit, but we do not have evidence that they do or they don't with the Delta variant. Next slide. So let's just talk about the principles of prevention. I feel like I'm preaching to the choir, but there are 4 things, and each one is important, and I'm going to list them in what I determine the most important down to perhaps the less evidence, but they're all important. Next slide. Well, vaccinate. This is the way we all know to stop the pandemic. Unfortunately, children under 12 years of age do not have a vaccine option. We need to get all children and adults to vaccinate anybody who's 12 and older. And if parents are asking you, how can I protect my kid? Well, we do like we do with other diseases. In cocoon children, we do this with preemies and neonates. We don't want them getting pertussis or flu. So making sure the parents, the children in the household have had Tdap or DPT, they're up to date on their pertussis vaccine, the flu vaccine, to protect the vulnerable. So we need to cocoon our children with vaccinated bigger people. Next slide. I was really very humored by, I saw the slide on the left, which is from, I saw it in social media, and it's from somewhere in the 1930s. And I just think it's very interesting, misinformation, and they're falling off the cliff because they don't want to be vaccinated against smallpox. And then the same week, The Week magazine, which we get at my house, had a similar cartoon about anti-vaxxers, anti-maxers, maskers, and you know, choosing to not listen to science and them falling off the cliff. I just think it's very interesting. So I think what it also tells us is, you know, the anti-vaccine history is not something that's new. I think it's harder today because of social media and it's all in our face all the time. But it is not new, and I encourage you to read some of the history, the history that's available. It goes all the way back, even earlier than the 1930s with the smallpox vaccine. Next slide. Just thought this was interesting. We're kind of playing tic-tac-toe. We're kind of playing Russian roulette, whatever. Why people don't get vaccinated. This is not a talk about that. I am puzzled just like you are about the concerns and the reasons people have not to vaccinate. Next slide. All right, social distancing. We definitely know this works. And keeping apart. And so if we're eating indoors, I think we need to remember that that's a time when we're taking our mask off and we have our hands should be clean, but social distancing, absolutely. So these crowded concerts, these crowded areas where people are, sports events, or just increases your likelihood of exposure. Next slide. Hand washing. We definitely know that hand washing works, and it's amazing when we all wash our hands, how we can diminish infection. And next slide. And then the controversy begins. Next slide. Masks. So we've had a lot of muddled messages. So I don't know if you can read this slide from the CDC. It's you put your mask on, you take your mask off, you put your mask on until you make them scream and shout. You got a new vaccination now. We say it's not enough. That's how we're sowing doubt. Anyway, you know the hokey pokey. So next slide. I've heard a lot about this. Do we know that masks reduce COVID transmission, especially in children? Well, I'm going to talk about some of the things that people are worried about. Some children are fine wearing masks. Actually, what we found is that you can teach children how to wear masks. You can teach autistic kids. You can't just slap it on and expect them to go, but you work with them, you put it on. Young kids, I've heard parents say, they get ready to leave and their 3-year-old says, car keys, masks, are we ready to go? Phone, I guess that's the other important one you need when you leave the house. So I think that most children are fine wearing masks. I think there are struggles. So I will tell you, I wear glasses, and yeah, my glasses fog. So I have to make sure how I wear my mask is so my glasses don't fog up. But I give you a little asterisk. So there was an op-ed in the Wall Street Journal by 2 physicians. One is an anesthesiologist, one is a peds ID specialist, and they really argued against masks in children. And they talked about glasses fogging, and they actually said, well, it's like medical students going in the OR and their glasses fog up. And after I read that, I thought about it and thought, so are you saying that medical students shouldn't wear masks in the OR? Are you saying that medical students shouldn't be in the OR? But then I thought, well, what about surgeons who wear glasses who are in the OR? They figured out how to not have their glasses fog. And actually, one of our trauma surgeons has talked to me about what she does, and she puts tape on her mask and tape in her glasses. So also when she's sweating, so her glasses don't fall off. So I thought that was really lame when you argue that someone can't wear a mask because their glasses fog up. Because it's not just kids who wear glasses, it's not just medical students in the OR who wear glasses, it's most of the adult population. So that I thought was really lame. Well, do they make acne and skin disease worse under the mask? Well, if your mask is getting wet, then you need to change out your mask. That's very clear. I don't know. I haven't talked to dermatology. I haven't seen any articles about that. I don't know. Do kids get distracted from learning? I think that's really pushing it. That's my opinion. I actually am not distracted from learning and teaching and talking by wearing a mask. I don't know. I think it's individual on that one. And there is only one single retrospective study about transmission of COVID with children, and the results were inconclusive. And so there is no answer on this. There's no scientific answer on this. Next slide. So is there possible psychological harm? Well, I think that we do recognize that we do learn a lot from facial cues, expressions. Babies' expressions are an integral part of learning. I'll tell you, I just saw about 5-week-old baby who was a little preterm, so corrected was maybe 2 weeks. And I will tell you, the baby engaged with me and I talked to the baby And I was smiling behind my mask, and maybe my eyes reflected smiling and positive interaction, but that baby responded to me and I was wearing a mask. So I think that yes, there is some loss in interpretation. I do think that children who need to read lips or are hearing impaired, I think there's a challenge there. I think that people who cannot articulate and speak clearly, I have a family member who has cerebral palsy. He is extremely hard to understand in a normal time, but when he wears a mask and it's muffled, it's really hard to understand him. But I think that we cannot say that there, well, there's no data that there's permanent psychological harm. I think there's a lot of psychological harm from COVID and our isolation, and I think there is more anxiety and there is more depression. Is this going to be permanent in people? Are people going to be resilient and maybe learn some lessons from all of this? I think the answers are yes to all of those things. Next slide. So what about mandates? Well, Ireland's Department of Health has mandated that they won't require masks in schools. I think they've left them optional. We have many southern states that have passed laws that say that no one can mandate masks, including schools, but now there are court cases where they're allowing a school, they're overriding the state mandate. There's a threat in one of the southern states of withholding pay from superintendents who mandate, and the superintendents have said, I won't take a salary, then you can take my paycheck. So there's fights about this. We are all aware of it. CDC and the American Academy of Pediatrics have jointly said all children should be masked in schools. Next slide. And a letter was written jointly by all of these state organizations, including our state AAP chapter and WVU Medicine Children's, with Women and Children's in Charleston and Hoop Children's at Marshall, urging the state to mask all children in school. Next slide. I love Mr. Rogers. So here's what this says. Mr. Rogers would wear a mask and also validate our emotions about why masks feel hard and scary, but are still vitally important to wear. Next slide. So that's what I have. There's a nice little cartoon of varying people wearing masks. And I'm going to open it up to hear what people have to say. And I saw there was a very robust chat going on, but I haven't read all of them. So maybe we can open up for questions. And oh, I see. Thank you. I think it's Lisa. Specifically, here are some resources regarding if masks delay speech and language development. Anyway, questions.
Thank you so much. That was wonderful. Yeah, we'll open up the floor. I did have a question from a participant sent in, if anybody wants to address that in a moment. But first, I just wanted to open up and see if any of our other hub members had any questions or comments related to this before we dive deeper into those questions.
I wanted to see that last cartoon for one more second. I didn't get all the way through.
Okay. Give me a second. Can you guys see that?
Yes, we can. Thank you.
Yeah.
I particularly like the guy in the bottom right corner with the, I think they're underpants on his head, the purple shirt. I mean, that one's pretty good.
Thank you.
Of course. All right, well, one question that was sent in, it is, an employee of the state has sprayed chemicals for eliminating COVID, such as in a school. This first chemical they were given was to be sprayed in a room and they are to exit. but did not receive PPE to protect themselves. Now the person developed a chemical pneumonia. Is this an issue the state will be seeing take place, and is it viable for research?
Wow. Well, I'm glad that NIOSH is next door to us because I think they'll be all over that one. Yeah, that's occupational safety and health. Well, I would think so. I'm no expert on that. Anyone else have a comment?
I just think that, people not having access to PPE and not wearing it is sometimes a different situation. So, there's a lot of people. My dad was a steel mill worker. He was given ear protection. He didn't wear it for a long time. And now he wonders why his hearing is not as great, So I think it's a matter of, really getting into, unfortunately, a lot of this has just become political. And so I think, I agree with Dr. Moffat. I think that's a better question for NIOSH. I'm sure they're probably already looking at that in regards to other chemicals, but in theory, they should have been wearing PPE regardless, because at the time when we went back to school, there was a mask mandate for everyone.
I see that you're muted, but it's not coming through.
Dr. Weissman, you might have to change your audio source, and you can do that by clicking the little upward caret button by your mute button. It might just be a different monitor or sound system.
Okay, I just tried that. Did that work?
Yep, it's
Yes.
working.
Thank you for the technical assist. So I'm probably the only person from NIOSH on the call, and what I will say is that we have something called the Health Hazard Evaluation Program. So if the folks at the school or at the setting where that chemical was sprayed wanted to put in a request for NIOSH to do an evaluation, they can go to they can just do a Google search for health hazard evaluation. And, there's a really clear way that folks can put in a request, or the local or state government can contact us and ask for technical assistance. That way we'd be able to get into the details of it, figure out what happened and make recommendations.
Perfect. Thank you so much. Really appreciate that. And thank you for the links. I think Dr. Casella, you were adding different links in chat. I'll make sure that those are into the recap. I think another question that had not been addressed yet is discussing antigen testing versus PCR testing and prediction of transmission. Is there anybody that has any comments about that?
We haven't done a lot of antigen testing here. We really haven't. Lisa, do you want to comment on the antigen testing?
Yeah, I think by and large, PCR is still considered pretty much the gold standard. I think a lot of the more rapid tests are antigen. I think there's a lot of things if a person's symptomatic, asymptomatic, transmissibility is really measured through the public health, epidemiologic investigation of, contact tracing. That's what we saw in Providencetown, Rhode Island, what's caused a lot of recent media, in regards to vaccinated people, spreading the virus, notably with the Delta. So they didn't link that back to any one particular, super spreader event, if you will. So I think that's where we really get a lot more of that data about transmissibility. There's been studies done about looking at viral load of, that are present in the nasal, area to determine what the amount of viral load is, and then could that, potentially increase transmissibility. So I think that in regards to testing, PCR is still by and large favored. I think there's more antigen type testing just from the rapid nature of such. Those tend to be, I think, more helpful if you are somewhat symptomatic or test after a period of known exposure.
Thank you
Thanks.
so much. Go ahead.
There was a
Sorry.
question in the chat about the third dose of the vaccine. And yes, I have several immunosuppressed patients who've already had 2 doses And as long as you're 28 days from your second dose, they can go ahead and get their third dose. So yes, we are already giving it. And I think then the question is going to be about all the rest of us and a third dose. And I think that we're not doing that, but I think it's what, 8 months? I think is what I'm hearing now, Lisa, is that right? It's 8 months after your second dose?
Yeah, yesterday the Biden administration came out and they are anticipating that boosters will be available for the larger population starting September 20th. ACIP is meeting again on August 24th. If you listen to their last meeting that they had on the 13th, they started to frame the discussion of what that will happen with boosters. I think it's very important, I'm putting on my messaging cap, to differentiate between them. I know it's really nuanced science, but right now, what is authorized from the FDA and the CDC, which is where we get our guidance from, in regards to what is known to be safe thus far, is that there's an additional dose for moderate to severely immunocompromised. Now, that's patient attestation. So are there cases of individuals attesting that they are moderately or severely immunocompromised? And they are. Who knows? We know they reported data that there were 1 million people across the country who got somehow a third dose of vaccine before this guidance was ever issued. So there were individuals out there for whatever, finding their way to an additional dose. So right now, what's been authorized is an additional dose. Booster doses are anticipated in, September. I think ACIP will have more guidance, and these are only for mRNA. I think that's really important. They have not yet come out with a recommendation for the viral vector, the Johnson & Johnson Janssen product. And so we've already heard reports of individuals, getting another J&J dose that's not recommended. And so, certainly I think Dr. Moffat, as always, gave a great presentation. I mean, I think, she talked about, like, there are people somewhat panicking. I think that, we need to kind of take a deep breath. I know it's been a long journey, and kind of wait and follow the guidance, because what I'm waiting to see is, will the booster dose be the same amount, or will there be a recommendation for a different? That's part of the issue that's been a significant delay in children, because they are looking at different doses for children under age 12 and what would be the recommended dose. I think those of us who work in pediatrics want them to speed that process up, and there's many individuals who feel there's already adequate data to support authorization for children under 12, but that's still not yet been fully granted, and unfortunately there's not much there's been not much said from CDC or FDA, despite multiple groups, multiple comments at the ACIP meeting trying to urge that. So I think if you care for a person who's moderately or severely immunocompromised, certainly getting that additional dose. Right now, the CDC and FDA still haven't authorized booster doses for the more general population, although we anticipate that just within the next month.
Perfect, thank you so much. I see another question. Before Delta, we heard that 15 minutes was a relatively safe amount of time to be around someone. Is the 15-minute recommendation still in place, given that Delta is so much more contagious?
Yeah, I think it is. I mean, I think this is something we don't know. I know I read on one of Clay Marsh's blog reports talking about there being a fog of aerosols, and you can walk through it and you can get it. So I've thought that about COVID all along. What's the magic about 15 minutes versus 1 minute versus 5 minutes versus a half hour? I think it's just practical. If someone is coughing, and you walk right in front of them, well, and you don't have a mask on, then is the possibility there? Yes. But the 15 minutes still is in effect.
Thank you so much. These are really great questions, everyone, and great conversation. Thank you for answering. Are there any other comments or questions that we have, or one that I didn't come out to? You can do a raise hand, unmute yourself, It's a safe space, so please feel free.
This is Lori from Infection Control. I just want to remind everyone on the call that supply chain in the hospital does have clear masks available. Our speech therapists have been using them for quite a while. So if anyone feels that they have language barriers or need the clear mask, they are available from supply chain.
Good to know. I didn't know that. Thank you, Lori.
Thank you so much, Lori.
I think that's great. And I think, to comment on Dr. Moffat's earlier point, I think parents have a harder time with it than children, quite frankly, in regards to actually being able to wear the mask. And personally, I think I will forever wear a mask in the hospital because I've really liked not getting the critty crud since February 2020, where I usually always, particularly in the fall, 1 or 2 weeks after I was on a 1 or 2 week inpatient stay, I always tended to get something. So I've really liked not having that. So, masks prevent against other things. And I'm personally worried. I don't think we're talking enough about flu season. Last year at this time, we were already starting to encourage people to get influenza vaccine. And we're just not really seeing that same type of emphasis being placed on an upcoming flu season that, I think certainly is going to be here before we know it, particularly as we do anticipate these booster doses coming for COVID, right around the time that we're then soon going to be recommending influenza vaccine. So you can co-administer. So, but I think that, as Dr. Moffat highlighted, they prevent other diseases too, and we know that they're circulating.
Well said. Thank you so much. Yeah, I usually always get sick, so I didn't get the flu. So it was pretty amazing. Does anybody else have any questions or comments?
I wanted to share, there is going to be a COVID, this is targeted more toward providers, both outpatient and inpatient, but a COVID management update on Tuesday morning at 8 a.m. that will also be recorded. It's going to be given by yours truly. I will post the Zoom link in the chat. My focus on this talk is really to go about the monoclonal antibodies. In some areas, we've really not used them when they have been one of the tools that prevents hospitalizations, particularly in our patients who are at high risk for severe disease. But we also have approval now to use it as a post-exposure prophylaxis. So anyone who has been exposed to someone, you don't have to rule them out before you can give the same dose as a post-exposure prophylaxis. And so I will be covering that, as well as some updates on inpatient management treatment as more studies have come out. So I'll put that in the chat, and I can also email it out to Elizabeth or Mithra to share with the group.
Absolutely, please do. I'd be happy to put that in the recap for everyone. And thank you so much for that. So I do have a question. Should those that are vaccinated, should I go get tested once in a while again if I do feel like I have a cold or whatnot? Or is it, I don't know, or is it just kind of?
If you have symptoms, so if you have a cold, sinus congestion, cough, with headache, fever, yes, you should be tested. But to be randomly tested without any symptoms, I think is not needed. That's my opinion.
Thank you.
I just wanted to chime in on testing. There's been a lot of talk about antibody testing, if you have been vaccinated. And I would love my much wiser and more brilliant colleagues, Dr. Weiss and Dr. Moffat, to chime in, but the CDC doesn't recommend it. And I personally don't think we know how to interpret those results. So unless it's part of a research study, Dr. Reese as well, please chime in. I think it's hard to interpret that. Like, what do we do with your, if you get tested and whatever it is? What I will say from the ACIP meeting, the people who have the best immunity are the people who had COVID and got fully vaccinated. They're the ones that have, shown to have, the most robust immune response. So I think when we talk about testing, I've seen a big push about people wanting to go get antibody tested if they've been vaccinated to determine if they should get additional vaccine. But I personally don't see much utility in that because we don't know how to interpret those results.
Right.
I have a comment about that. So I have a friend who contacted me, And so she had COVID last year. And she also, I think, had she had a previous, what's the neurologic disease after influenza vaccine sometime?
Guillain-Barré.
Guillain-Barré. So she had Guillain-Barré after a flu vaccine in the past. And so she's going on a trip to Germany to visit one of her children. And she's going to run the Frankfurt half marathon and the Berlin marathon. It's like, oh, you should get vaccinated. She's like, I don't want to get vaccinated right now because if I have, some kind of a side effect, I won't be able to train and I want to be able to run this marathon. And so she went to the doctor and said, can you do serology on me to see if I'm still protected? And they said, no, under no circumstances, we're not going to pay for it. I'm not going to order it, blah, blah, blah. So she went to somewhere else, like a Doc in the Box or something, and they ordered it. And her level was 131, whatever it is, nanograms per ml or whatever the things are, and protective is greater than 0.8. And so she said, okay, since I have high protective levels, I'm going to continue with my plan of not getting vaccinated until I return after I run my marathon. To me, that was a rational sort of series of thoughts and a rational reason to do it, and so on. I think in the public health point of view, right, we talk a lot of times about like hepatitis B vaccine, or we talk about measles, mumps, German measles, and getting those serologies versus getting the shot. I was in the military for almost 30 years. People would never say, well, let's check your serology. No, it's from a public health point of view, it's less expensive and more expedient, whatever, just to get the vaccine. But for particular situations, like my friend brought up, I thought that's perfectly reasonable request, and it shouldn't be like barred from getting information that makes you that helps you make a decision on that. That's my 2 cents.
Right, I agree. I think in that situation, I think the people who have been vaccinated choosing to get antibody testing to then determine, if they need an additional dose is what I think there's been a lot more, and it's CDC doesn't recommend it, and that's what I think. I just don't know the utility of in that situation.
So I don't think we have data yet on the opposite of what Lisa said, is that you've been vaccinated and then you get a breakthrough case of COVID. Like Ray said, should we have a COVID party now that we've been vaccinated? I don't think we have data yet. That data will come out. I'm sure it'll come out to see how protected are you then from subsequent. Should those people who've been vaccinated, got breakthrough, should they have this booster dose then? I think we don't know. Now, there was another question in there about following one vaccine with the other. And I'll tell you, I've read a little bit about that because it has been looked at, and there's no recommendation that you jump vaccines. I think the more of the data is that there's no harm being done, but I don't know that there's a benefit that you go from mRNA vaccine to a viral vector or back. So I use caution on thinking of doing that, because I don't know if anybody else has a comment about that.
I have 2 sort of follow-ups with Dr. Weiss's example. Would you ever use, or what do you think the utility of antibody testing an unvaccinated person with no known COVID in more so an attempt to say, hey, you have no immunity, get your vaccine, in some of these hesitant people?
That might not be a bad idea. I'm afraid it would backfire, because if they have an antibody, because they've had asymptomatic or mild, what we know is that their immunity is way less than if you're vaccinated. So what Lisa said is, having had COVID, then get vaccinated, your immune response is really good. But if you have natural COVID, you're at risk for getting Delta again. You're at risk.
Right.
But you're right, Ray, that might be a way that to say, hey, you have no protection. You haven't had it. You don't have you don't have herd immunity from, or not herd immunity, but you haven't had even an asymptomatic infection. And yes, you need to. So I think we have to be careful because it could backfire on us on that.
And do you think that there would be utility in getting, I got Moderna, should I get Pfizer?
No,
in
you should stick
September?
with Moderna. No, that I think they're. I think they want you to stick with when you get your third dose, you stick with the one you started with.
Yeah, that's correct. I mean, fully vaccinated is still considered 2 doses of an mRNA or 1 dose of J&J. I think we're all waiting to see what that data will say, but I was on a call, I always mispronounce his name, but Mike Olgerstrom or whatever from Minnesota, he was on like Meet the Press this past weekend. And I thought what he said is like, we need to all be careful to not try to replicate ACIP or, these established, like well-known experts, like leave the recommendations to the experts. I think we've seen a lot of individuals want to come out with their own thoughts, but that further leads to misinformation, which as Dr. Moffat clearly articulated, there's a lot of misinformation and disinformation out there. So I think it's very clear, stick with one, not because they said they haven't been vaccinated or whatever, but I don't think we have data right now that supports the need for that.
Right.
Thank you so much, everyone. Are there any final questions? Let's see, hold on. Couple, is there any information about improved immunity vaccine response with getting both mRNA vaccine and viral vector vaccine?
Yeah, that's what we said. There is some limited data, but not to do that. Now, are there any contraindications to the vaccine? Well, they're not live vaccines, so an immunocompromised person can be vaccinated. I think we know they may not respond, and that's why we're giving a third dose to the moderately to severely immunocompromised. But otherwise, there's the usual of having a severe allergic reaction. But actually, I read about a study that looked at people who had large local reactions to their first vaccine dose. So they would have been the mRNA because they're 2 doses. And then they were supervised and they all tolerated and didn't have a problem. And I've talked to a lot of people I've really encouraged them, go get that second one. Nope, it's okay. I think anaphylaxis is a contraindication. Or talk to the allergist. Let's talk to the allergists in those groups. But otherwise, no, there are not contraindications.
Michelle Tracy brings up a really good question in the chat. Why the recommendation shouldn't be talk to your doctor. Because if the doctor said, oh no, you're immune compromised, you shouldn't get the vaccine, that's actually not
right.
It's not a good recommendation. The recommendation is especially you should get the vaccine. One of the things that, I'm lucky enough, or I think most of us were lucky enough, in my opinion, to get the mRNA vaccine, which has the highest efficacy. And you just wonder about people who got, for example, J&J, and it's only 65% against getting infected, but it's 98% or whatever the number is against severe disease. Like, oh, if we have to get more vaccines, could I opt for an mRNA vaccine so I'm even better protected? To me, that's not a bad question.
I think it's a great question. I think we just don't have the data. That's what we need, that data. We need it sooner. We already needed it. And so, because I do think that there's concern that there, might need to be additional doses or or vaccination with another product. But yeah, I just want to echo, I think, because there's a lot of health professionals on the call, there's a lot of changing information, but I've heard time and time again, just improper guidance coming from a healthcare professional, and data from the beginning, specific in West Virginia and across the country, healthcare professionals are the most trusted source of information. So I think it's, if you don't know, say I'd have to look that up than trying to just say, because I think there can be a lot of unfortunate harm. I've heard many cases, somebody had Bell's palsy, their provider told them, oh, you can't get vaccinated. That's not true. The clinical considerations that I shared in the chat, I always keep that tab open. The CDC also has a line that you can call for clinical consultation, but there's actually very few contraindications. Like the only one is anaphylaxis to the actual mRNA vaccine. And like Dr. Moffat said, the allergists are talking about that if it's truly, if that should even be a true contraindication. So the information is still constantly changing, but our recommendations go really far as healthcare providers. And I think it's important to be careful. If we don't know, we just need to be frank and say that and try to find the answer, to the best of our ability.
Yeah, so in the chat, I think there was something on Fox News last night about if you have MS or you're on MS drugs, you shouldn't be vaccinated, and that's wrong. They're the most vulnerable. Yeah, I did hear Anthony Fauci say early on that it's sort of like if you're on a roof and a lifeboat comes by and you'd rather have a helicopter, take the lifeboat if there's a flood, because the lifeboat is what you need. So at the time, if you were offered the J&J, you took the J&J, you don't have a choice. But I think that if we do have a choice of vaccines and we see what the efficacy is, then choosing the mRNA, vaccine. But I think when there isn't a choice and you're offered one and that's the one that's available, you take it.
Thank you so much. All right, we're at the time. I apologize. Great conversations, but just in the interest of time, I'm going to make that final announcement and set the poll. Thank you so much. Really appreciate all your expertise, every single one of you, and all that you do through these trying times and our normal times as well. So our next session will be September 16th, and we'll be focusing on the Delta and the other variants. And then I'm just going to set that poll.